Bismillahirrahmanirrahim. In my last lecture, I discussed about the odontogenic mesenchymal tumors. Today, this lecture would be about the mixed odontogenic tumors. The mixed odontogenic tumors are that group of the tumors which are composed of the proliferating odontogenic epithelium lying within a cellular ectomesenchyme resembling the dental papilla. The learning outcome for this lecture would be what are the different types of mixed odontogenic tumors? How do they present clinically, radiologically, and histologically? What are the important differentials and the best treatment modalities? Ameloblastic fibroma, odontoma, and ameloblastic fibro-odontoma, all of these lesions, they come under the heading of the mixed odontogenic tumors. First, we'll start with the ameloblastic fibroma. Ameloblastic fibroma, it is a circumscribed lesion which is located over unerupted molar in young patients. This is a true mixed odontogenic tumor, which is usually seen in first and second decades of life with a mean age of 14 years. Seldom it is seen beyond the age of 14 years. It is slightly more common in males than females. Approximately 75% of the ameloblastic fibroma, they occur in the posterior mandibular region. Localized swelling and or failure of teeth to erupt on time and improper alignment, all these may call attention to identify the tumorous condition. Generally, these lesions on radiography, they appear either as a unilocular as well as they may appear as multilocular radiolucencies. They tend to be well defined and they may have a sclerotic border surrounding these unilocular and multilocular radiolucencies. Approximately 75% of these lesions are said to be associated with the unerupted teeth. So in this slide, upper right corner, there is a picture of a boy with a swelling on his left side of the face. In the upper left corner, there is a radiographic depiction of the same boy, which shows a unilocular radiolucency in the posterior mandibular location. If you see closely, you would identify that there is an impacted mandibular molar which is lying within this radiolucency. On histopathology, the ameloblastic fibroma, it is composed of the strands and cords of the odontogenic epithelium, which are lying within the embryonic connective tissue. These strands and cords are lined by hyperchromatic, cuboidal, or columnar epithelial cells. All these epithelial cell cords and islands are lying in a loose ectomesenchyme tissue. In some areas, zones of hyalinization may be seen surrounding these odontogenic epithelial strands. Differential diagnosis for ameloblastic fibroma are the central giant cell granuloma, ameloblastic fibroma, and odontogenic myxoma. The treatment for this lesion is usually the conservative surgical excision is usually considered sufficient to treat these lesions. But in some cases, 20% of the recurrence rate has led some surgeons to recommend a more aggressive approach in order to reduce the chances of recurrence. Odontomas. The odontomas, these are the most common odontogenic tumor. These are considered as hamartomas rather than the true neoplasm. These hamartomas or odontomas, they are commonly associated with unerupted teeth. There are two forms of this odontoma, compound and complex. In compound, you will find the tooth-forming components such as enamel, dentine, pulp, and cementum in the recognizable teeth shapes. However, in complex, these tooth-forming elements are found in conglomerate masses. So what is a hamartoma? A hamartoma, it is a focal malformation that would resemble a tumor grossly as well as microscopically. It results from the faulty development in an organ. It is usually composed of abnormal mixture of tissue elements which are normally present in that site where they develop. So this is picture in this slide. The left side of this slide, there are solid, small gray-white structures. However, in the on the right side of the same slide, there is a OPG which shows a large radiopaque mass in the posterior mandibular region, and it is surrounded by a proper corticated border. The odontomas, these are usually seen in the first and second decade of the life with a mean age of 14 years. Usually they are asymptomatic. Commonly, these lesions are seen in the maxilla. Compound form of odontomas are seen in anterior region of the jaws, whereas the complex are usually located in the posterior mandibular locations. On radiography, the compound appears as unilocular lesions with multiple small radiopaque structures that resembles the miniature teeth. Sometimes these lesions contain miniature teeth ranging from 3 to 4, and that goes up to hundreds of tooth-like structure. Recently, there was a case in Faisalabad where the surgeon removed more than 200 miniature teeth from young boy. So I guess this was the highest number of the miniature teeth that was reported from Faisalabad. In complex form of the odontoma, these are again the unilocular lesion. Usually they are small, but they can grow up to a large sizes that may range in the size up to 10 centimeter. They appear as a solid radiopaque mass, which is surrounded by a thin zone of the radiolucency. So this slide shows two radiographic pictures. On the right side, there is a small solid radiopaque structure that can be appreciated in apical areas of the anterior teeth. On the left side, a large radiopaque mass can be identified just over the impacted molar tooth. On histopathology, odontoma presents as single conglomerate mass of the enamel, dentine, and pulp in case of the complex odontoma. In complex odontoma, you cannot identify enamel, dentine, and pulp. They all will be present in the form of a single gnarled mass. All these may also contain some reduced enamel epithelium, secretory ameloblast, and odontoblast. Usually, these extra structures, enamel epithelium and odontoblast, these are usually not recognizable in under usual conditions. Some spherical calcification may be seen in complex form of the odontomas. So this is the histopathological picture of a complex odontoma. Please remember, in complex odontoma, you may find enamel, dentine, and dental pulp-like structures, but these will be in the form of a conglomerate masses. Normal structures would not be possible to identify them as a normal structures. So the elements of the complex odontoma, the blue arrow, it shows the dentine in the lower half of this photomicrograph. The blue arrow points towards the dentine, developing dentine. If you go towards your right side of this photomicrograph, you will find a black arrow pointing the enamel. This is a developing enamel. And if you go in the middle and towards your left side, you may find a yellow arrow that points towards the enameloid matrix. On histopathology, compound odontoma presents as enamel, dentine, and pulp. They all are arranged in an orderly fashion where they are surrounded by a follicular connective tissue. So this is a picture of the compound odontoma. On a higher magnification, you may find a black arrow which points towards the follicular epithelium. Just beneath this black arrow, you may find, or just adjacent to this black arrow, you may find a blue arrow which is pointing towards the enamel, developing enamel matrix. The black star which shows mineralized dentine, and just underneath this mineralized dentine, there is an arrowhead that shows a dental pulp. Differential diagnosis for odontoma are the focal sclerosing osteitis, osteoma, periapical cemental dysplasia, ossifying fibroma, and cementoblastoma. Basically, all these lesions, they include the radio-opacities. That is why these all are included under the heading of the different, these all can be listed for the differential diagnosis of the odontoma. Just remember one thing, that odontoma in its initial stages, it can be radiolucent. But as the time passes and as the radiopacity develops, with time, they become mixed radiolucent and radiopaque structure. And in later stages, when the fully, this lesion is occupied by the full whole solid mass, so on radiography, it will appear as a radiopaque structure. Treatment for this odontoma are the simple local excision, and usually their prognosis is excellent. They do not recur. Ameloblastic Fibro-odontoma. Ameloblastic Fibro-odontoma, it is a tumor with the histologic features of ameloblastic fibroma in conjunction with the presence of the enamel and dentine. So it means the presence of the enamel and dentine material within the ameloblastic fibroma makes it a ameloblastic Fibro-odontoma. There is a great potential for this tumor to grow, and these may cause air destruction. Fortunately, these are only these odontogenic tumors. They represent only 1 to 3% of all the odontogenic tumors. So usually these tumors, they present in first and second decade of the life as an expansile growth in the younger patient. Usually these lesions are encountered in the posterior mandibular area, and they arise in area of unerupted teeth. Pain is usually not encountered in these lesions. On radiography, they appear as unilocular, well circumscribed, sometimes mixed radiopaque and radiolucent lesion. Opacities are usually diffuse and nodular. However, in some cases, they may contain an impacted tooth. Variable amount of the calcification with radiodensity of tooth structure are the frequent phenomena in ameloblastic fibrodontomas. So the microscopic picture of ameloblastic fibroma, it shows both the soft tissue component as well as the hard tissue component. In soft tissue component of the ameloblastic fibroma, you may find strands and cords of the odontogenic epithelium that resembles the dental lamina. However, the connective tissue would be resembling embryonic connective tissue, just containing the fibroblast, just like the ectomesenchyme. So from your ameloblastic fibroma, the soft tissue component, the ameloblastic fibroma histopathological picture of the ameloblastic fibroma, just recall that in your mind and put the complex form of odontoma and fit that in the ameloblastic fibroma. So you will get a picture of the ameloblastic fibroma. Hope you got my point. So this is the histopathological picture of the ameloblastic fibroma. So ameloblastic fibroma, this exhibits if you see number 1, it demonstrates the odontogenic mesenchyme. The number 2, it shows the odontogenic epithelial cords. And the number 3, it shows the hard tissue. So ameloblastic fibro-odontoma, it is actually the mixture of odontogenic mesenchyme, odontogenic epithelium, as well as the hard tissues. Differential diagnosis of the ameloblastic fibro-odontoma includes odontoma, calcifying odontogenic cyst, adenomatoid odontogenic tumor, and calcifying epithelial odontogenic tumor. Another name for this tumor is Pindborg tumor. The treatment is simple enucleation and surgical curettage is usually sufficient to eradicate these tumors. That's all for today. Thank you so much.